Hello, everyone. We are here to discuss implementing the second international guidelines on the management of BK polyomavirus and kidney transplantation. And it's an honor to be here with you with Professor Nassim Kamar, who is from Toulouse, where he runs the transplant program and was a very active participant in the BK guidelines. I'm Camille N. Kotton. I am from Massachusetts General Hospital in Boston, where I'm the clinical director of transplant and immunocompromised host infectious diseases. And I was one of the main organizers of the BK guidelines. So we're here with you to talk about all things BK. And I hope that you will learn a lot over the course of our discussion. We have some conflicts of interest to disclose, as you can see on this slide, and both of us will be discussing off-label use of diagnostics and therapeutics. So just by means of background, BK causes premature allograft failure in about 10 to 20% of kidney transplant patients if they don't undergo routine monitoring for BK in the blood. So screening and monitoring for BK replication is key. Treatment involves reducing immunosuppression, and there's an increased risk when they have kidney allograft rejection because of the intensity of immunosuppression. Sadly, there are no vaccines or antiviral drugs that are approved for prophylaxis or treatment. And the last international guidelines from the Transplantation Society or any group were back in 2005. So we thought it was high time to update them. So the Transplantation Society requested an update of the guidelines, and we were lucky enough to receive independent fundings from Roche Diagnostics, so they had absolutely no role in guideline development. And the leadership was assigned to both me and Hans Hirsch in Switzerland. And we used the American Society of Transplantation Infectious Disease Community of Practice 2019 BK guidelines as a starting point. And then we sent about 80 invitations to international experts based on the recent publications in the field and contributions, and roughly 50 of them accepted. And we formed into various working groups involving epidemiology, pathology, diagnostics, treatment, PKPD, pediatrics, and cost benefit. We did a review of the literature. We did an evaluation according to grade, and then we made a big document with proposed recommendations. And then we met in a hybrid format in Basel, Switzerland in April of 2022. Roughly half people were virtual and half were in person. And then we had a very vigorous discussion on definitions and guidelines and all of that. And then the manuscript was published in Transplantation this past June. So we are thrilled to have gone through this process, thrilled to have support from Roche. I will say that the Transplantation Society is a very international organization, as you can see on this map. There were people from all over the world, and all continents were represented at the meeting, so we were very fortunate. We wanted to represent high, middle, and low-income areas where they are doing organ transplantation, and we were able to do that. So I'm proud of that accomplishment. Here's a picture of all of us at the guidelines meeting, and both Nassim and I are in that picture. We used GRADE, which I'm sure many of you are familiar with, to rate both the quality of evidence and the strength of the recommendations. And that is, you can find that throughout the document, and we'll be talking about that during this webinar. So a clinical vignette. So this is my case. It's a 62-year-old man who had end-stage renal disease due to lithium toxicity. He was on dialysis for 5 years. He underwent kidney transplant from a deceased donor. He was given antithymocyte globulin and was on steroid-free immunosuppression. He had delayed graft function. His nadir creatinine 2 months after transplant was 1.7 milligrams per deciliter. 3 to 4 months after transplant, his creatinine rose from 2 up to 3, so not going in the right direction. We finally, 4 months after transplant, measured his BK, which was 5.6 copies per mil. And then we rechecked that on a different system at a different laboratory. It was still 1.7 million copies per mil. And then 2 days later, it was 3.6 copies per mil. and the urine was very, very high. So we clearly had a diagnosis of high probability for BK. This is actually an old case, and it represented a time before we started doing routine screening. This is his kidney biopsy. No surprise, I'm sure, to anybody in the audience, but his kidney allograft biopsy 4.3 months after transplant showed severe polyoma nephropathy. So really tragic case, and really shows the lack of what can happen when we don't do good screening, because we only started testing 4 months after transplant when a lot of the damage had already been initiated. So his immunosuppression was reduced. We gave monthly IVIG. By 8 months after transplant, the BK was undetectable, but his creatinine was 4 mg per mil. And he had progressive worsening of his creatinine over time with a loss of his graft 5 years after transplant. Truly tragic case.
Yeah, so thank you, Camille, for the introduction for BKV problem in the transplant field. It's really a huge problem now for us, because now we are dealing very easily or quite easily with acute rejection, with some infection, but BK virus remained a huge problem since, as it has been said earlier, we do not have any efficient treatment, we do not have any vaccine, and we will discuss another case and we'll show you that we may have some different patient's profile. To the first one that has been presented has clearly showed you that without any screening, things can go wrong very fast and rapidly. We have the patient with a high BKD anemia and finally BK virus nephropathy. And now I'll present you another case which was expected to be a very simple kidney transplantation case from my center. So it was a very young guy, 38 years old man who has an IgA nephropathy. He has undergone a first kidney transplantation in February 2009. He had been on dialysis for 1 year. He was group A, similar to the donor. It was the donor was his wife, 39 years old, so it was a ABO compatible transplantation. He had no HLA antibodies, so it was non-sensitized, so it was quite low risk transplantation with ABO compatible, HLA compatible kidney transplantation from a living donor. So you are expecting to have something very, very easy to handle. CMV status was D plus R plus and EBV was D plus R plus. So when we had to transplant this patient, we decided not to do any induction therapy since he was at very low immunological risk, and we started immediately after transplantation tacrolimus, targeting a draft level between 7 and 10. We gave mycophenolate for 1.5 milligram a day and steroids. In addition, as we do for an all patient, we give him some CMV prophylaxis with valganciclovir. D plus R minus, we decided to give him 3 months prophylaxis, and trimethoprim sulfamethoxazole for 6 months. So everything was going quite smoothly. We were expecting to have something very easy to be handled. And finally, this did not happen exactly like we thought. So everything was okay after transplantation. Kidney function decreased rapidly and went back to 120 micromole per liter. So I'm not talking in milligram, but in micromole per liter. So you have to divide by 9. And everything was okay at 1 month. And at that time, we did not look for BKV viruria. We did not look for the BKV in the urine, but we did it at 1 month in the blood. And this is what we are doing in our center, and it was absolutely nil. Nothing was happening. But 1 month later, we checked again for BKV, and as you can see, he went back from 0 to nearly 4 logs copy per milliliter, which is very, very high. And when his tacrolimus trough level was at 8.6 nanogram per milliliter, so within the range that we have decided, and it was not very high for a patient who is getting a first transplant without induction therapy. And 15 days later, we checked again for the viremia, because since we had a first positive the anemia, we did it a second time to 15 days later, and he was nearly at 5 logs. So probably we performed the kidney biopsy because he had a slight increase in the kidney function. He went up from 120 to 150 micromole per liter, and the biopsy showed us some inflammation. According to the BAMF classification, it was I2T2, the tubulitis. SV40 staining was positive. You can see it on the lower part of the slide. C4D was negative, and as expected, he didn't have any donor-specific antibody. So finally, we have the diagnosis of a BKPyV nephropathy that occurred at 2.5 months after transplantation, very early after transplantation, with a patient having no expected risk factor for BKV. So this is an important point to discuss. The first point that we can discuss with Camille is what are the risk factors to develop a BKV nephropathy. If we look on what we were able to collect in the literature during the consensus meeting, we have identified some risk factors. And if we go back to our patient, he didn't have no severe immunosuppression, no polyclonal antibody use, no previous transplantation with a graft loss from a BK-virus nephropathy, and he was quite a young guy, and we had observed that risk factors may be an older recipient. So this was a patient with no real expected, at least, risk factor. And when we go through all the literature, and we had finally the only risk factor that had been really identified in the literature, and we can consider it as evidence level as high, was the use of tacrolimus. And this was based, if you remember, on a previous study called the DIRECT study, in which kidney transplant patients were randomized to receive either tacrolimus or cyclosporine A with mycophenolate, and patients were screened for BKV. And in this study, the risk of BKV was higher in patients given tacrolimus. So this is an important point to focus that finally in our patient, the only risk factor was only the use of tacrolimus. So I don't know, what do you think, Camille, about the use of immunosuppressive drugs in this in this setting? But finally, when we observed the first viremia in this patient, we were really surprised.
Absolutely. I think one of the things that came out of the guidelines, I mean, it was amazing to do this massive literature review and to use GRADE and all of that. I was sort of hoping that we would have more salient risk factors so that we would know that we just need to focus on a certain population. But unfortunately, tacrolimus is really the one of the risk factors that had sort of the most risk, but it is widely used now. So it's not like we're going to stop our tacrolimus, or, it's sort of hard to know what to do with this. And it's somewhat disappointing. We were hoping that maybe with a good literature review, like maybe we would be able to find a high risk population, but unfortunately that wasn't really possible. So this just really shows the importance of screening everyone. And I'd like to second what you said, that so often we've had several cases of BK lately, like significant BK DNAemia or viremia. And it's amazing how you can't predict who's going to get it, right? And that's one of the biggest issues.
One of the points that we have observed, it was published in the literature, and we found some few cases that probably or possibly some seropositive donors who will give the kidney for a seronegative. So in the setting of D plus or minus, we can increase the risk of BKV, especially early BKV. But as you know, there is no serology now available for this, and the majority of the people are seropositive.
Right. 85% of people are seropositive, and then there's not good serologic testing. So that was one of the things that we said. We really hope that there could be better either serologic testing or cell-mediated immunity, right? And that's among the things that we listed in the future directions and epidemiology and risk factors.
Yeah, and because in fact, what we observed, for example, in some few cases, that ABO-incompatible patients were at higher risk of having a BKV infection, but we do not have some robust data to see if they are really at high risk or not. There are some papers suggesting that probably giving mTOR inhibitors will decrease the risk. It has been partly showed in some prospective study, but that were not dedicated to look only on BKV. For example, in the Transform trial, where the patient received CNIs and mycophenolate, or CNIs and mTOR inhibitors, the risk of BKV viremia was lower in the patient receiving CNIs and mTOR inhibitors, but the study was not designed to look specifically on BKV. So this further studies are really required to see what is the real risk factors and how can we predict in the future patients with BKV. So currently we are not able to predict anything at transplantation.
Right, right. And then there was always a lot of discussion around, right, mTOR inhibitors, how to optimize immunosuppression. Can we look at neutralizing antibodies against the donor BK serotype? How do we use tortinovirus in this setting? And is there a role for that? And then there are just so many questions.
Another important point to discuss, and this is for the nephrologist, and we spend a lot of time to discuss, when should we do a biopsy? You know, when we look for the classification, we can use several classification. The AST one, we can use the one of the BANF classification, and we can look for the BKV. Should we do SV40 staining in all patients, on all patients with BK viremia? So everything was discussed, and it took us a lot of time. And I can tell you that nephrologists who are pushing to have biopsies, where the others who are not nephrologists are saying, okay, if the patient have a very high viremia and a decrease in kidney function with no really risk of acute rejection, probably we cannot do it. But finally, we decided that probably we should do a kidney biopsy. And as a nephrologist, I'm very happy to read this, especially when it's clinically indicated. In other words, if the patient has any increase in kidney function and having proteinuria, hematuria, etc., we should do a kidney biopsy, at least to rule out any other problems, because we may have acute rejection, we may have a relapse of initial nephropathy, so we should do the kidney biopsy. On the other hand, if you just have an increase of BKD anemia, what we are all expecting to do, and we'll discuss it later on, is to decrease immunosuppression. If the kidney function is absolutely stable and nothing happened, and especially if the kidney biopsy is at risk, we cannot do it in all patients. And with respect to SV40 staining, the question was, should we do it in all patients? And finally, we did not suggest to do it in patients with negative BKV anemia. The probability to have positive SV40 while the patient has no BKV anemia is nil. So we did not ask to do it for all the patients, but if the patient is at risk of BKV nephropathy, or if we are suspecting, it should be done if it's possible.
Yeah. The pathology section was really well done. Part of the goal was to sort of decrease the need for biopsy or optimize when we're doing biopsies. So trying to not make more work, but optimize our workflow for everyone.
And we still have a lot to do in the pathology, because we may have some discrepancies between what we observe in the biopsy and what's happening in real life. All the biopsies are not interpretable. So this is why we have put some future directions, some other new things that we should do. We have to compare different classifications, and we have to do try to develop some non-invasive assays to detect also the nephropathy, because we are doing this now for rejection. We can use donor-derived cell-free DNA for acute rejection. What should we do in the future for BKV? So there are a lot of things to do to have the diagnosis of BK virus nephropathy. But one of the more important points, and probably this was really highlighted by the case that presented Camille, is the screening. And so in my center, we start screening 7 years ago, and now we are really strict on the screening. But you know that some centers are still not doing screening systematically. And this is a very important point. And I think Camille will focus on this point, how many times you should look for BKV anemia in these patients.
Yes, so we were quite clear, and hopefully this is helpful to programs so that they can develop their own protocols. As you mentioned, you have your protocol, we have ours. As I mentioned in my case, we weren't initially doing screening for everybody, or it was erratic or not universal. So we do recommend that everybody undergo routine screening. We do generally recommend plasma, not whole blood, but plasma testing monthly until month 9, and then every 3 months until 2 years after transplant, 3 years for pediatrics and pancreas transplant. And then if the results come back and are sort of in that low range, the 1,000 to 10,000 copies per mil or equivalent, we would recommend repeat testing in sort of 2 to 3 weeks. And then if they do have sustained plasma loads greater than 1,000, we would recommend ongoing monitoring every 2 to 3 weeks to assess the dynamics and response to interventions such as reduction of immunosuppression. And then in patients, if we always said in our center, treatment of rejection resets the clock back to day 0. So if they do undergo treatment for rejection and increased immunosuppression, we would do monthly BK checks on blood for the next 3 months. We were very appreciative of people in the room who were coming from resource-limited settings who didn't necessarily have easy access to blood testing. And in that setting, we recommended the use of urine decoy cells, screening for urine cytology for decoy cells. And if positive, then we would recommend doing the blood testing. Or they could also do urine screening and then flip to blood testing if the urine testing were, say, greater than 10 million copies per mil of BK. For pancreas transplants, we did recommend screening up to 36 months. And then we had a pretty good consensus for non-kidney solid organ transplant recipients. We don't recommend routine screening, but if somebody has, a rise in creatinine and there's no obvious explanation, then we would screen likely BK in blood in that setting. So we're hoping that, for me, the screening part of the guidelines was especially helpful in that it sort of established parameters in both high, middle, and low resource settings as far as what routine screening should be. In a bit, we'll talk about cost benefit and why it's really important to actually screen everybody in order to maximize the cost benefit.
So what do you think about the use of urine testing and trying to decrease immunosuppression before viremia becomes positive?
I wish it were more helpful to me. I find urine testing so high. So many people have such high BK levels that it seems of unclear significance. So I think it's important to, to test the blood to confirm what your blood level is, because that seems to be a much more solid number. What do you think? Would you agree?
Yeah, but what I still do in my center, we still do both. In fact, we do urine and the blood at the same time. And sometimes we have the patient who have increasing viruria while viremia is still negative. So at that time, we start reducing immunosuppression before viremia became positive. But I completely agree that if you do viruria, you should do viremia at the same time. So in this case, probably the cost will be higher. But I don't know what will be the proportion of patients in whom we will decrease immunosuppression and who will not move to positive viremia. So, in France, everything is quite easy to get, so we do both, but it's not the same. That's not the case in all centers for sure.
Yeah. Well, that would be good to collect that data. That I have to say, one thing, putting together the guidelines, there was such an absence of good, clinical trials data. So it was a little hard to put together robust guidelines, and we're really hoping that a lot of people who participated in the guidelines or who are listening now could actually contribute more to the field so that we could, really understand more, because it's, as you said, such an important issue, and then there haven't been as many clinical trials as we might have hoped for. we did put together this flow chart. I mean, there's sort of a lot of questions about optimizing therapy, and I always think a picture is so easy to follow. So, here we have going through the kidney transplant, and then the next arrow is doing the monitoring until month 9, and then every 3 months until 2 years. More often, if indicated, if the creatinine's going up. We included screening in children, and then if there's a detectable BK, so people use the phrase viremia, but it's technically not really accurate because when you're doing PCR, you're actually just looking for fragments of DNA. So the technical term that we use is DNA-emia. But if you have detectable BK DNA-emia, going through the flow chart, if they are high immunologic risk, you may wish to do a biopsy. We'd recommend confirming the BK, and then if they're high immunologic risk, we'd want to do a biopsy. And then if they're not high immunologic risk, you may just wish to reduce the immunosuppression and keep checking for BK, and kind of, circling through. And hopefully this picture would be helpful to people. We were hoping this is the kind of thing you kind of, stick on the wall in clinic and just refer to as you're going through your clinical work. We do think that biopsy is really important especially for people with elevated creatinine, because one of the great issues is that they can have both significant BK DNA-emia, but they also could have rejection. So if they are at high immunologic risk, really important to consider doing the biopsy, think about what you're going to do for anti-rejection therapy. This is one of the hardest things we manage because you both want to reduce and increase immunosuppression at the same time. But a lot of details would be in the biopsy results, and that's where we'd have you refer to the pathology section for additional details. This is a beautiful graphic that just shows the timelines of BK replication and related events. And you can see that initially patients start having BK in their urine, either through DNA urea or decoy cells. A little later, they get the DNA-emia. Sort of earlier on, they have BK-specific antibody levels that go up. Later, there's a cellular response. And then even later, they can have the allograft-directed immune response. And you can see here, drawn in is near the bottom is the net state of immunosuppression that's been overall decreased. And they may have bumps in their creatinine along the way. But this is sort of a nice graphic that was put together by members of our working groups to show what the timeline is, and just so that people can think about when they're screening and what is happening at each time point during increasing and then decreasing DNA-emia and when people have cleared.
You have already discussed what should we use, how should we test for BKV. One of the important points, at least to try to use the same test when you are testing the patients. And we strongly suggested that plasma should be used rather than whole blood for detecting BKV anemia. And normally the question, should we present the data as international user per ml or copies per milliliter? And it took us some few hours discussing this issue. And at the end, the most important is to have at least the same test and to have the same way of presenting the data to be able to have the follow-up of the patient and not to mix everything.
Definitely. Pick one and stick with it. Hopefully.
So for the future, we have discussed several things, and there are several things that can help us in the management of these patients. We discussed the serology. Also, as we said earlier, more than 80% of the patients are seropositive. But one important point will be in the future, probably the use of CMI, because we can use, how can we go for having the immunological anti-BKV status before the transplantation? How can it predict what will happen after transplantation? What will happen when we modify the immunosuppression? So there are a lot of studies to do. It's a huge field of research that's open now, and probably thanks to the improvement on all immunological tools, we can use a lot of things, and we should to focus on this to try to better identify the risk of the patient who are at risk of BKV in one hand, and on the other hand, once we have replication, to see how, when we're managing our immunosuppression, what will happen for the BK response. So I think this is an important point, and we will have a lot of things to do in the future. So let's go back to our patient, and in this slide you will see that we used a lot of things. If you remember, I started in 2009, and a lot of people discussed a lot of strategies for treating BKV nephropathy, and I show you how we can mix a lot of things. So when the patient had the BKV nephropathy in the beginning at 2 months and a half, we decided, first of all, to reduce immunosuppression. Our first step reduction was reducing the MPA dose from 1.5 gram a day to 1 gram a day. And in the same time, we also decreased a little bit tacrolimus from 8 to 6 nanogram per milliliter. And finally, we did not have a real impact. But if you remember correctly, on the biopsy, we had inflammation and tubulitis. And at that time, we were still not knowing if it was BKV alone or BKV plus acute rejection. Camille said sometimes we may have both. So the patient was giving steroid pulses. And finally, nothing happened. After steroid pulses, they have a slight increase in the anemia, and then it decreased. Since it was still high, between 4 and 5 logs, we decided to modify the immunosuppression. So the first step is we stopped MPA, and at that time we have some data suggesting that leflunomide can be useful in this setting. And there are several papers in the literature. So we moved from to MPA to leflunomide. Nothing happened. And again, we said, okay, let's go for something else. So we stopped tacrolimus and let's go for mTOR inhibitors. So in one slide, you have a picture of all what we did during at least in 1 year. The patient had a reduction of MPA, a reduction of tacrolimus, a conversion to mTOR inhibitors, and a conversion to leflunomide. And at the end, at 9 months, he was still between 3 and 4. So probably when the patient at the end was given only sirolimus and leflunomide, we were probably had really decreased his immunosuppression, and this can explain the slight decrease in the BKV, the anemia. But it was not sufficient, because 15 days later, he had a flare-up of BKV. He had a real increase in creatinine level, because he moved from 150, 160 to 260. So we did again a second biopsy, and the second biopsy showed a huge inflammation, E3 and tubulitis, with IFTA, interstitial fibrosis, and acute tubular atrophy, and we were with positive C4D staining. So we were wondering if it was the BK virus, the flare-up of the BK virus nephropathy, or it was an acute rejection, a T-cell mediated rejection, since we really reduced immunosuppression. So we gave again steroid pulses, and nothing happened. Instead of improving the patient, creatinine level increased nearly to 300 micromole per liter, and at the same time, the BKV, the anemia, increased. So we used what we thought at that time as an efficient or possible efficient treatment. We used cidofovir. So the patient was giving 1 milligram per kilo per week for 6 weeks. And you can see that after the end of the 6 weeks, we had a slight decrease in the BKV, the anemia. However, kidney function was not good at all. It was at 400 micromole per liter. So it was nearly doubled in nearly 4 months. So we did again a biopsy, and the biopsy showed us again huge inflammation and a progression on the fibrosis to 20%. SV40 was still positive, and C4D was negative, and the SA negative. So at the end, we decided to go back to tacrolimus. So the patient was giving tacrolimus, steroids, and we said told the patient that probably he will lose his kidney very rapidly, because everything is going very fast, and we at that time used everything that we knew that we had, And 1 year after the transplantation, he had already a very, very bad kidney function with a quite bad histology. So how can we manage immunosuppression? And this is a real problem. What we are supposed to do in patients with BKV nephropathy? Of course, we need to look for the concentrations. We have to monitor BKV to see what's happening and to try to get it as low as possible. And there are two strategies in the literature, and we can discuss it for probably 2 hours because all the data in the literature are not so robust. So we have one part of the people in the room who were telling we have to decrease anti-metabolite first, and the second part was saying no, we have to decrease the CNIs first. You can look in the literature. Both strategies have been used. Both are useful. Which one should we prefer? I don't know. So this is why we decided at the end, our consensus was to say, let's use both. Strategy 1 or strategy 2, you have to choose.
So this was such a big discussion, right? Which one we should do. When I was at the Transplantation Society meeting, we had, this big international meeting, and I was talking about BK. I did an audience poll, and most people prefer reducing the anti-metabolite. I don't know what you think about that. I was really interested because in the audience, more people preferred reduction of anti-metabolite rather than reduction of calcineurin inhibitor. But that's not what was happening at our meeting. We were more like 50-50. I thought that was interesting.
Yeah, for me, if we are trying to increase the T cell response against BKV, for me, it seems more logical to decrease CNIs, which targets more T cells than MPA. But I don't have sufficient data to support this. And what's really interesting was the discussion about the use of mTOR inhibitors and the use of other drugs. And you have probably seen a paper that will be published soon. It's online now from the group of Strasbourg in France who looked for the patients who have been who have with a BKV anemia who are randomized either to receive low TAC with a reduction of MPA or low TAC and everolimus. And they did not find a beneficial effect of using mTOR inhibitors. Conversely, it was more harmful to use TAC between 4 and 5 nanogram per milliliter and everolimus. The study was very well done. It was very interesting, but the main point in this study that the doses of mTOR inhibitors that have been used are the same than the one have been used in the Transform trial to prevent acute rejection. So we can summarize the result of this prospective randomized trial that using the same trough levels that are able to prevent BKV nephropathy are not sufficient to treat BKV nephropathy. So I think we still need more data with looking with low TAC and low mTOR inhibitors. Otherwise, we still have a heavy immunosuppression. So currently, we can decrease CNIs, we can decrease MPA, we can probably, without any published data, use mTOR inhibitors, but the main point is to reduce immunosuppression. We can use some additional therapies, Camille?
Yes, I think, that talking about adjunctive therapies or not using adjunctive therapies has actually been one of the most popular parts of the guidelines, in that what people had told me that they really appreciated, because we actually say in general, don't use cidofovir, don't use leflutamide, don't use fluoroquinolones, and don't use statins outside of, clinical trials or something, because they have not been shown to be useful. So, many of these drugs have significant side effects. Cidofovir can be nephrotoxic. Leflutamide is immunosuppressive. Fluoroquinolones can certainly have side effects, as can statins. And so we actually say don't do all those things. For Intravenous immunoglobulin, we say that you can try it, especially if they've had an insufficient response to reduce immunosuppression to help facilitate viral clearance. But that was a weak level D recommendation. And then we also suggested, so that's gentle, intravenous immunoglobulin administration as adjuvant therapy to prevent acute rejection. And again, that was weak and level D. So really, unfortunately, other than reduction of immunosuppression and possibly use of intravenous immunoglobulin, we don't actually recommend any of these other adjunctive therapies. But I think clearing the air so that people could understand, because as you mentioned, the use of leflutamide in your program, and certainly we were doing that. We used fluoroquinolones at one point. We've all done these things, but it is helpful to sort of realize that these things are not useful.
Absolutely. And what happened to our patients finally, when we left him at the last slide, he was at 1 year with very bad kidney function. And finally, with low TAC and low steroids, he was able to keep to have his kidney functioning until 11 years. And after 3 or 4 years, BKV became negative, and kidney function remained stable until 2018 or 19. He had the flu with ARDS. He required dialysis, and even after this, he was able to be dialysis free. And finally, in 2020, unfortunately, he got COVID, and at that time he went for dialysis. So this is a really picture of patient in whom we have used all what we can use. Finally, we don't know if something worked or not. Probably retrospectively, no. What worked probably is the reduction of immunosuppression to having low TAC and low steroids without having leflunomide, mTOR inhibitors, cidofovir, and he was able to have his kidney functioning until 11 years. And so the same patient come back after 2 years on dialysis, and he show up. He was negative for BKV, the anemia, despite slightly positive BKV DNA viruria. He had, in the meantime, had 2 bacterial infections, 1 peritonitis, 1 chronic HIV infection, and he asked to be retransplanted. And this is something that we are faced to sometimes, patients who lost their kidney from BK virus nephropathy, and he was asking for retransplantation. So, Dr. Kotton, the nephrologist, I'm asking you as an ID, should I retransplant this patient?
Yes. And we had a lot of discussion about this, right? And so I would say he's young and otherwise healthy, and some of those opportunistic infections or infectious complications are sort of standard. So we do recommend retransplantation in people who are otherwise eligible, who have lost their prior allograft to BK nephropathy. We do recommend that BK DNAemia be resolved prior to retransplantation. And it's interesting how some people can actually be off pretty much all immunosuppression, back on dialysis, and still have some DNAemia. So we do recommend that they really clear that. I suspect with these ultra-sensitive assays that we may see some very low, results that might not be so worrisome, but we don't have data on the lowest possible threshold. And then there was a lot of debate about whether they needed a graft nephrectomy, but we decided that people should not undergo a graft nephrectomy prior to undergoing repeat transplantation, as long as they've cleared their BK DNAemia. If they haven't cleared their DNAemia, perhaps in rare situations, you may wish to consider the graft nephrectomy, but that's a significant surgical procedure, so we would not recommend that. And then there's a big question about what to do with immunosuppression the next time they undergo transplant, and should you manage them any differently? And we really don't have information on that, but we would say just screen them carefully, keep a very close eye on those folks, but we think they'll probably be okay.
I fully agree. So we do not do a nephrectomy, especially in patients with who have cleared the virus. I think we should not do it because it's a harmful surgery, and we don't have to do it.
Yeah.
So we have to go back to your clinical case now.
Yes.
What happened?
It's so sad. He had progressive worsening of his creatinine and lost his graft 5 years after transplant. You know, highlighting we should have been screening early. We should have been screening monthly. We did reduce immunosuppression, but after the BK had already done some damage, and we also gave IVIG. But I think, you know, with BK, early detection is where it's at. This was certainly not cost effective in that he ended back up on dialysis, and dialysis is very expensive. So it would have been wise if we had been screening. And tragically, he was determined to be too frail for repeat transplant. He otherwise would have been a candidate from a BK perspective, but he was just too frail, so he ended up on dialysis. So it's sort of a really sad story about kidney transplantation. We had a great cost-benefit group that in part led by Jermaine Wong and others, but it turns out that screening is actually quite cost beneficial, and we do recommend routine screening, you know, monthly times 9 months, and then every 3 months for a total of 2 years after that, since it is improved in clinical outcomes and because it's cost effective in multiple robust models up to the 7th decade of life. There was a lot of discussion, like, can we do less screening and save some money? But for cost benefit, we suggest not decreasing the frequency of screening because it can reduce the efficacy of the intervention by reducing immunosuppression and increase the overall direct healthcare costs. So it turns out that if you are thinking like, oh, I'll do some of that screening, but only every 3 months, it's actually not cost beneficial. And I would ask you to look at the section of the guidelines, and you could certainly message with Jermaine Wong and others, because that was actually quite insightful. So I think overall we had a lot of highlights from the guidelines. We've summarized what we've learned and what we know, and we've certainly learned a lot since 2005. We were hoping that this would also help standardize practices across centers in various countries and parts of the world. And we also were hopeful that it would cut back on non-effective therapies outside of clinical trials, you know, the quinolones and cidofovir and leflutamide that really shouldn't be used anymore. It also emphasized to us, as the 50 experts who were involved in the meeting, how much we need to learn and investigate, and there's so much work to be done. So I would encourage everyone who's listening, if you have data sets, if you have interesting cases, if you have, you know, any type of publication, you know, data that you could share, we really would encourage that. And I know both Nassim and me and Hans Hirsch, we'd all love feedback on the guidelines and your center and whether this works for you or doesn't. We do have a lot of questions in the Q&A, so we're happy to tackle those, or happy to have feedback as well.
Yeah, so we have some few questions. I start with the first one that I discussed earlier. What do you think about the results of the BKPyV trial? So reducing MPA or using mTOR inhibitors. As I said, it's a nice trial. It was very well done. It showed that probably using tacrolimus and everolimus at the trough levels that are used to prevent rejection are not the good strategy if you want to use mTOR inhibitors. So I don't have data, published data, but we are looking forward to have some data showing that probably having very low tacrolimus and low mTOR inhibitors may be beneficial, because it's not the prevention of acute rejection trough levels, but for treating BKVD anemia, but the data are not available yet. So probably we need some data to work on this topic. I'm not convinced that we should rule out completely mTOR inhibitors. We should move forward and try to find something that could be helpful. So what do you think, Camille, about the use of a PCR before a transplantation?
So it's a good question. We don't have any data on that. I don't think that doing PCR testing before transplantation in someone who's not immunosuppressed is likely to be useful. However, there are some patients that are quite immunosuppressed heading into transplantation, and that's probably a good idea to look at those look at those patients and perhaps do, a one-time test shortly before transplant, because you wouldn't want to be surprised. We sort of don't know the role.
We did this several years ago in kidney transplantation from living donor, and we had observed we do not have viremia because none of the donors was viremic, but we had observed that when the donor had a viruria, then we had a higher risk of having viremia in the recipient afterwards. That was a small study, very few patients. And the question, if the patient is positive, if we put on one side the living donor, what will you do if you have a deceased donor? You will not postpone the transplantation. You will do it, and probably you'll modify a little bit the immunosuppression. But it should be done, but we have to decide what to do with this in the future.
Yeah, so I'd say that remains in a research, like future directions as far as what we should do. But that would be that's a very good research project.
Yeah, absolutely. And do you have I do not have it in France because it was not approved in France. What's your experience with the use of cellular therapy against the BKV, Camille? Do you use it? How many?
We don't have access to that.
We don't have access to that neither. So.
Yes, I think that there were some companies. There was a company that was developing this primarily in the setting of stem cell transplant, but I don't think. We have thought about cellular mediated immunity, so diagnostic tests to look at the risk of BK, but not so much the cellular therapies. That's definitely still future directions, I would say.
I agree. One discussion, how often should we perform BKvirus PCR? So as Camille said earlier, at least once monthly for 9 months and then every 3 months until 2 years. It's quite difficult to be done because some patients are living far from the hospital. They are not coming back. They do not show up, especially at the outpatient clinic, or they cannot do it in a private lab. So it's not very easy, but it's the optimal way to do it, at least the first year. But we know also that we have some BK virus during the second year. So we have to try to go to try to have it at least for the first 2 years, even if it's not so easy to be done. Another question. Yeah, urine versus plasma for BK testing. We have discussed it earlier too. We have a lot of patients with positive BK viruria without having a viremia. So what should we do if we have only viruria without viremia? Probably nothing. If we can do both, probably it will be better. But I agree with Camille. We have to look for retrospectively to our data how we modified the immunosuppression with viruria, and if it really avoided viremia.
But just to be clear, in the guidelines, we are recommending monthly blood checks, so plasma checks, and then I think that urine could be in addition and could be supplemental and may well be helpful, especially because on that timeline you detect viruria before you detect viremia, so it may in fact be helpful. But for now, if you have to pick one or the other, I would definitely go with plasma. That's what the guidelines suggested. This is a good one because you're a nephrologist, so I'm going to make sure I ask you, how do you exactly define high immunologic risk?
That's a very good question. So there are several ways to define the high immunological risk. Probably based on the current definition, it will be probably patient with the preformed DSAs who require desensitization protocols with apheresis, rituximab, anti-complement drugs, or bortezomib, or anti-plasma cells. So probably those are patients at high immunological risk. And probably we can add in this category ABO incompatible transplant patients. So in other words, all patients requiring desensitization protocol. But I have another question for you, that because I'm not ID, it's what should be the algorithm in post-stem cell transplantation for BKV?
Well, that's a great question. Definitely not what we covered in the solid organ guidelines. So this is a stem cell question. So, in general, we don't have data that we need to monitor stem cell transplant recipients. They tend to get hemorrhagic cystitis. So certainly any stem cell transplant recipient with hemorrhagic cystitis should be checked to see if it's caused by BK, adeno, potentially CMV, much less likely. But we don't actually have a routine screening algorithm for that population. I think if someone wanted to put together further guidance on BK in that population, that could be quite interesting. But for now, certainly not included in the solid organ guidelines and probably not needed on a very regular basis. There are lots of other things they should be screened for.
Yeah, there's one very good question. Do you recommend to test viruria before a second kidney transplantation after BK nephropathy graft failure? This is a very good question. In the guidelines, we did not say anything about doing viruria before the transplantation. However, in the future directions and what we should look for, we clearly wrote that we should look for the patient who are still viruric and who will undergo a retransplantation. I don't know if a patient who have lost his graft and he still was a high positive viruria will be not at high risk of relapse after retransplantation. It's not a recommendation, but it's in the future direction. It's something that we should do for research. At least we have to look retrospectively and to try to answer those questions, which is really, really very important.
There are a couple more questions. What is the relevance of positive JC, BK, PCR in kidney transplant? So I think this means JC virus PCR in kidney transplant recipients, and we don't really know. We do worry that that could evolve into the CNS infection PML, but I think that's not something that we covered in this guideline. I would make sure that you have, the right assay and that there's not overlap with other viruses, or, I'd look into the details of what you're testing for. There's another question on any experience of BK virus involvement in liver transplant rejection. And no, I would not actually. Usually when you have high BK, it's from over immunosuppression. So we don't think it leads to liver rejection. There's no data on that.
No, do you think it's a cell-free DNA a suitable biomarker during BKV anemia? Good question. I think it should be tested. I don't have any data to support it, but I think it's, again, a good idea for doing research to see if there may be an effect if the positive cell-free DNA results will be predictive of acute rejection rather than BK-virus nephropathy. It will be quite difficult, I think, to find the difference between both because both are acting on the kidney. But it's a very good question, and I don't have a real answer for this. So probably we have answered to all the questions. We kept the time. So if there is no other questions, I have to conclude. First of all, you have all observed that we tried, all the experts, and especially thanks to Camille and Hans-Serge, who were able to move forward in this guideline to try to have some guidelines that are up to date and stop doing what I clearly showed you in my case report, using some adjuvant therapy that are not useful anymore. We tried to think a lot. We do not have a lot of data for BKV. We still need a lot of data. We have to publish, we have to look retrospectively, we have to do prospective study, we have to try to determine what's the best policy. For screening, I think it's quite clear, but for the treatment, and once the BKV, the anemia is positive, we are really not doing very well for the moment. We are just trying to decrease immunosuppression and hoping that creatinine level will not increase, that BKD anemia will not increase, and we do not know. And each time the patient show up at the outpatient clinic, we are just looking for the result to see if what we did was correct or not, because we do not have absolutely not any marker of what we are doing. So probably what we can highlight in this guidelines that a lot of people worked on this, and this, you have the list of the people who worked in the different groups. We all worked, we all tried to look what's in the literature, but unfortunately it's still quite thin. We have to move forward and work on this topic. So as Camille said earlier, we'll be really, really very happy if people who attended the meeting would like to work on BKV, would like to share their experiences. We need to learn much more in this virus, that it's still a real problem for the all the kidney transplant physicians and the ID physicians who are in charge of these patients. So thank you very much, Camille. It was a great pleasure and honor to do this webinar with you. Thanks for Roche, who sponsored the meeting, for the ESOT with this platform, who allowed us to be able to present the data. So probably we are on time. I'd like to thank you very much and see you soon.
Yeah, thanks very much. Thanks for all your contributions to the guidelines and to the field of transplantation. Great. Thanks, everybody.